Good afternoon, good evening. Thank you so much for joining me for this presentation. We are going to be talking about dental hypersensitivity. Before we get started, I wanted to make you aware that I will be presenting information from various sources and highlighting different products. Please apply your own professional judgment and experience with respect to the information provided. I would like to thank VOCO for an educational grant, which allows me to share this presentation with you today. So a little bit about me before we get started. I received my certificate from Howard University, and I received my Master's of Health Science and my Doctorate of Health Science from Nova Southeastern University. I am currently the program chair at Fortis College Landover and adjunct faculty at the American Denturist School. I do own my own company, Dr. Joy RDH, where I do a variety of things, including writing and editing and professional speaking. And in my downtime, if that really exists anymore, I am an eyelash extension trainer. I became certified in 2006. So for those of you wondering what else can you do with a dental hygiene license, this can be a very rewarding and lucrative business for you. My family, however, is my biggest accomplishment. Pictured here is my husband, Kevin, and our 4 children. And I'd just like to say, I know that we have all been impacted by COVID in some form or fashion, some more than others. And despite all of the negativity and uncertainty, my family and I had a lot to celebrate as we ended 2020. In December, my husband and I celebrated 25 years of marriage. And on the same day, we also celebrated our youngest son signing his national letter of intent to play Division I football. A week prior to that, our oldest son, Kevin Jr., proposed to his now fiancee, Gabrielle. So every time I look at these pictures, I am truly reminded of my many, many blessings. So let's talk about dental hypersensitivity. What is it? As dental professionals, we are all likely familiar with this term. The condition itself is very common, and it is my hope that after this presentation, you will have a greater appreciation for your ability to be able to help your patients who may be suffering from it and potentially learn about some new treatment modalities. So by definition, dental hypersensitivity is a painful, common clinical condition, usually associated with exposed dental surfaces. It has also been defined as a pain derived from exposed dentin in response to stimuli which cannot be explained arising from any other dental defect or disease. So clinically, your patients will experience sudden, sharp bursts of pain. It's important to note that, outside of this presentation and as you are reading the literature, there are some common terms that are used interchangeably with dental hypersensitivity. So you may see terms like segmental hypersensitivity, cervical hypersensitivity, and of course, dentin hypersensitivity. So what actually causes dental hypersensitivity? So there are several theories that have been explored throughout the years to explain this phenomenon. And the most widely accepted is the hydrodynamic theory. Although it is the most widely accepted theory, it's important to note that even with all of these theories combined together, they still do not explain all of the occurrences of dental hypersensitivity. So what does this mean? It means that there's still much to be understood about this and that there are other unknown mechanisms that could be responsible for causing dental hypersensitivity. And that's exciting because that means we get to continually learn about this condition. It's important for us to keep in mind theories outside of the hydrodynamic theory, although that is the one that's most widely accepted. And that's important when we are considering the different treatment modalities, which we'll get into later on. There are theories like the nerve theory and the odontoblast theory, and you're going to need to decide if you want to use something that is really going to minimize the perception of someone's pain or simply place a barrier between the dentin and the stimulus. And so when you are, let's say, recommending treatments or evaluating the effectiveness of treatments, let's say you've prescribed something to someone and it's not quite working, thinking outside of the box sometimes and maybe exploring other theories may help you to maybe create combination treatments for your patients. So I just wanted to provide this bit of information for you. So what does the hydrodynamic theory tells us? So what it tells us is that individuals experience dental hypersensitivity when dentin is exposed to external stimuli. This external stimuli causes the fluid inside of the dentin to move in different directions. And this change in the direction of fluid, there's also an increase in the amount of fluid that builds pressure. So these two actions create an electrical discharge as pictured here. And this in turn stimulates the myelinated fibers, the A fibers, and that produces the neurotransmission to the brain that translate into pain for us. The odontoblasts, which are responsible for making the dentin, some studies suggest that, they're responsible for pain perception. They are responsible for signaling the brain as well. So when we talk about stimuli, there are various types of stimuli that, we can experience. So there's the evaporative stimuli, and you need to liken that to like air. Let's say if you're in clinic and you're blowing air. There's also chemical stimulus, or stimuli. So let's say if you have a patient that likes to whiten their teeth often, then there's the tactile stimuli. So aggressive toothbrushing or even periodontal debridement. So just your regular recare, how hard or how much pressure are you using when you're using your instruments? And then of course, there's the thermal stimuli. Now with the thermal stimuli, patients suffering from dental hypersensitivity normally will experience sensitivity to cold. Now, if they experience something, or let's say pain because of something hot, it's usually related to something else. Very rarely is it related to dental hypersensitivity. It's important to note, this term smear layer that you see here. So a smear layer is essentially a layer of debris on the dental surface, which is comprised of organic and inorganic compounds, and it can be removed by mechanical actions. So you can really only experience this sensitivity when that smear layer has been removed. So dental hypersensitivity, as I stated earlier on, is a common condition, and various studies will report different percentages, but on average, it is a common condition that affects about 57% of the general population. Studies suggest that the frequency is significantly higher for patients with periodontal disease, anywhere from 60 to 98%. It peaks between the ages of 20 to 40. Typically with a higher prevalence in women, but new data is showing that there are increasing numbers of younger adults suffering from dental hypersensitivity, and we'll talk about that later. There was a systematic review and a meta-analysis conducted by Ziola and colleagues in 2019. And with this, the prevalence ranges were observed to be as low as 1.4%, believe it or not, and as high as 92.1%. And a lot of those differences were attributed to the populations that they studied, the different habits, the diets, and of course, their methods of investigations. In the mouth, the buccal surfaces are at greater risk for developing dental hypersensitivity, with premolars being most affected, followed by canines. So that's not to say that no other surface can be affected, but it's important to know that this is typically where people will experience the pain, so that when you are educating your patients, or if you're asking questions, you can specifically ask, hey, have you ever experienced any pain around this particular area in your mouth? So in order for someone to experience dental hypersensitivity, there have to be two things that occur. There has to be an exposed surface, okay? So the dentin has to be exposed, and then the dentinal tubules have to be open. So tubules are canals that extend from the dentin to the pulp cavity. So in order for dental hypersensitivity to occur, there has to be an opening from the dentin layer all the way into the pulp cavity. In this, just imagine, I like to use a lot of analogies sometimes. So it's wintertime, and I know we're bracing for this major winter storm. And so typically most of us live in areas where there's smooth pavement. And so what happens when it snows and then everything freezes over, in order to bring everything back to normal, we throw ice down. And once that ice is cleared away, what we don't often see are those tiny microscopic cracks. Sometimes we see the holes. Now imagine you are the construction worker. Your job is to fill those holes. And what you have to do is figure out what the best material is to fill that hole. And so what are the things that you're going to consider? Well, maybe the material you use is sensitive to temperature. You have to consider the wear and tear. So those are things that, keep that analogy in mind as we start to talk about different treatments. Interestingly, there are up to 30,000 canals that can be present on a single tooth. And so when you are considering a product, you want to make sure that you're going to use a product that can spread and cover those 30,000 openings. So scanning electron microscopy found that someone who is suffering with dental hypersensitivity has 8 times more dental tubules, and these tubules are twice as wide. And this is versus someone who's not experiencing the dental hypersensitivity. And so with the wider tubules, there's more fluid flowing back and forth, so there's more pressure. So this is a situation where less is definitely more. So what causes dental hypersensitivity? There are so many different causes. And I have erosion highlighted here because erosion is the #1 factor contributing to dental hypersensitivity. The thing is, we can talk about this for 5 to 6 hours because there's so much to learn about it. There's so many different products, but the reality is we only have 1 hour tonight. So I really want to take some time to focus on erosion. Of course, diet, whitening, and personal behaviors all lend themselves to erosion. But in fact, I think that many of these conditions lend themselves to one another. So that's also important to keep in mind when you're talking to your patients, or maybe if you're, performing a differential diagnosis, trying to determine what is actually wrong with your patient. Your patient could be suffering from dental hypersensitivity for multiple reasons, not just one thing. So dental erosion is the irreversible loss of tooth structure. And I cannot stress this enough, that erosion is due to chemicals. It's the chemical dissolution of acids that affects the tooth structure. Pathogens are not involved with dental erosion. That is a carious lesion. So what happens with erosion is that the hardened structures become really soft, and in a softened state, they become susceptible to mechanical wear. Erosion is a superficial condition. So anytime there is a subsurface lesion, you are dealing with a carious lesion. Like caries, however, dental erosion itself is multifactorial. There are various things that can cause it. It's important to note that attrition, abfractions, and recessions, while they themselves do lend themselves to dental hypersensitivity, they are loss of tooth structure because of physical means and not chemical means. So when I say dental erosion is a multifactorial process, it involves several different things. So there are behavioral factors that we must consider. So what are the eating and drinking habits? How is an individual brushing? How many acid challenges are they experiencing a day? Are they having any GI issues? What do they do for a living? And by that mean, certain carpenters, Depending on what you do in construction, you may hold certain things in your mouth, or if you have a high stress job where you're constantly picking at your teeth, that could be a contributing factor. And then there are biological considerations. And by biological, I mean, what is the environment like in your mouth? And saliva. Saliva is so very, very important. And I think it's one of the things as dental professionals, we don't really talk to our patients about. But is there a lot of saliva flow? What is the pH of your saliva? Soft tissue movement. It's very, very important. What is the anatomy of your teeth? How are they structured? And then, of course, you have chemical factors. And so, what's the buffering capacity in your mouth and things of that nature. And then even outside of that, we talk about education and then socioeconomic status and then habits and health and knowledge. And I'm even going to add values. So you take all of those and you take your tooth, and then you have time. And then depending on what factors are involved, this is where you get erosion. So it's important to note that the mouth is constantly in a state of remineralization and demineralization. And Stevens curve here explains how long it takes for the oral cavity to return to a neutral state after an acid challenge. Now, remember, I explained that erosion is caused because of chemical dissolution of acids in the mouth. So in the mouth, enamel is highly susceptible when it falls below a critical level of 5.5 pH. We know that 7 is neutral, but it's important to note that root dentin is susceptible at 6.7. So every time you eat or drink an acidic beverage or you consume fermentable carbohydrates, the pH in your mouth can fall below those critical levels. So it can take 20 minutes for your mouth to return to a neutral state. And in that neutral state is where the remineralization process starts again. If you drink something that's acidic, or again, those fermentable carbs, it can take 20 minutes for your mouth to return to that neutral state. And if you eat something that's highly acidic or a fermentable carb, it can take 40 minutes for your mouth to return to that neutral state. So let's think about this. For you coffee drinkers out there or people who like to drink soda, are you sipping on your coffee or are you sipping on that drink? I'm going to even throw tea into the mix. Are you sipping on that beverage throughout the day? If you are, every time you take a sip of that beverage, that 20-minute clock starts over. So for some of you and for some of your patients, those poor teeth can't catch a break. It's like they're slowly eroding away in a sea of acid. So have you ever stopped to consider how many acid challenges your mouth is undergoing every day? I want to take a moment to focus on diet. The Western diet in particular is very acidic. It is very high in sugar, and it leads to a constant bombardment of acid attacks in the mouth. And when you are part of clinical management, and I'm skipping ahead, but part of the clinical management of dental hypersensitivity is having these types of conversations with your patients. And one thing that I would like to see dental professionals use more in clinical practice settings is the nutritional assessment. We do the caries risk and we do the cancer risk and we do the perio risk assessment, but we need to be doing a nutritional assessment. And this is really, really important when we start to eliminate some of the causative agents of dental hypersensitivity and how we can help our patients moving forward. As we were growing up and even now, we're told that fruit is good for us, right? And yes, in small amounts, fruit is good. A lot of, I'd say, food companies market fruit juices to kids. And I'm saying this because, again, as I stated, for the prevalence rates, we're starting to see dental hypersensitivity more and more in younger populations. So, sometimes your kids, they don't want to eat their fruit, they don't want to eat their vegetables. And so what do these companies do? They tell you, well, hey, why don't you give your kid some fruit juice in place of the regular fruit or vegetable. And the thing is, the acid content in some of these juices is just it's just astronomical. And the thing is, our ancestors only ate fruit when it was in season. And now we have access to so many things. And if you think about it, there are people who will drink a gallon of orange juice in a day. That's like eating a basket of oranges in one day. Now, how realistic is that? And it isn't. So, having access to things and portion sizes is really what is causing some of these problems. I also want to highlight sports and energy drinks. So the sports and energy drinks, number one, they are not the same thing, but the terms are often used interchangeably in the literature. They are being marketed to children and adolescents for a variety of reasons. It's $1 billion energy. And so they're marketed to young children and adolescents because it, suggests that they can enhance their athletic performance. It helps with the replacement of fluids and electrolyte loss after, sweating and exercise. They are also marketed as a means to boost energy, to decrease fatigue, enhance concentration, and mental alertness. And what we know is that these sports and energy drinks are high in acid content. These drinks are also very, very high in caffeine. And I just kind of wanted to put this out here. The amounts of caffeine in these drinks is unbelievable. And I found this to be interesting. In 2005, the American Association of Poison Control Centers, they reported 4,600 calls for questions regarding caffeine. And of that 4,600, there were 2,600 cases that involved people 19 years and younger that required treatment for caffeine overdoses. So, there are other issues that are happening with these younger kids as well. So again, when you're having these conversations with your adolescents or the parents with younger kids, talk about the acid, but let them also know, because, as dental professionals, we treat the whole body, that there are other dangers with these drinks as well. Yes, some pediatric athletes can benefit from the use of sports drinks, but with a well-balanced diet, studies suggest that water actually is sufficient to replace those sports drinks. And especially in the school lunchroom, again, with a well-balanced diet, water could definitely be a suitable replacement. But it's interesting that, are you really drinking water? When I first started to study this when teaching nutrition, I was floored. My students and I did an exercise where we just decided to get bottles of water. And I was just curious. I'm like, I wonder what the ingredients are for water. And I'm just thinking, hey, it's just H2O. And I had a particular brand of water where everything that was listed had acid at the end of it. And I'm like, this isn't even water. Now, remember, we talked about critical pH being 5.5 for enamel and 6.7 for dentin. Where if you take a look at this chart, you will notice that some of these so-called waters have a pH as low as 3.5. That is the same as a soda or your Red Bull. So yes, water is great, and we all should be drinking water, but depending on the type of water that we're drinking, we are still putting our teeth under this acid attack. So calcium, the calcium ion content as well as pH were found to be really good predictors of the erosive potential of beverages. So typically beverages that are supplemented with calcium, they have a reduced capacity to demineralize enamel. So there's some good news there. So let's move on and talk about how dental hypersensitivity can impact the quality of life and well-being. Maybe for some of you, and for your patients. So people who are suffering from dental hypersensitivity often report displeasure when they eat and drink something. So sometimes they will develop these coping mechanisms. So they will go away to hide when they eat because they don't want other people to see them experiencing that pain, or maybe they will drink through a straw. I know for me, when I was younger, I used to love biting into lemons. And when I got married, my husband would always look at me and say, "Why do you bite your ice cream like that?" And I would literally fold my top lip over my teeth before biting into ice cream because it hurt so bad. Other people reported coping mechanisms that included avoiding brushing or flossing the affected area, which we know is not helpful because what happens when that biofilm is just allowed to sit there, it further demineralizes the enamel. Certain people will avoid eating particular foods, or they are going to avoid eating and drinking altogether, which then leads to other concerns because we know that the oral structures in our mouth have to have certain vitamins and minerals to thrive, if you will. And then some people even avoid going to social gatherings. They will avoid talking or smiling to prevent exposure to cold air. And I want you to think about it for a minute. Imagine how much someone has to be suffering for them to avoid talking, smiling, or going out. And what we're finding is that people who are suffering from dental conditions like this start to suffer from depression. So it's very real. So when our patients, come to us and they say something hurts, we should never be dismissive because we never want it to get to a point where they are socially isolating themselves. So clinical management of dental hypersensitivity is possible. It is possible. Unfortunately, many patients don't view dental hypersensitivity as a dental condition. So they dismiss it as a simple inconvenience. And sometimes we don't hear from them until it's too late. The thing is, there are steps to clinical management. Ideally, you want to start with the least invasive procedure, and then you want to work your way up the ladder. What I find is that most people start in the middle, and you'll see what I mean here in the next few slides. So let's discuss the very, very first step, and this is the one that is often missed. You have to identify the cause. Think back to the slide, look at the arrow where it says start here. That's the very first thing you need to do. The very first thing you need to do is not slap on varnish or hand your patient a paste, an over-the-counter product. You need to have a conversation. You have to identify the cause, because if you identify the cause, you could potentially eliminate the cause. So you have to talk, ask the right questions. You have to be like a detective, if you will. It's also important for you to identify the cause so that you can rule out other causes, maybe like pain or a cracked tooth. So when you are identifying the cause, what you really should be doing first is your assessments. And with your assessments, you must have a thorough medical history, because a thorough medical history can give you insight into what are some of the things that may be causing, i.e. like medication. Conducting a thorough medical history involves using really good motivational interviewing skills. So in addition to a good medical or health history, you also want a thorough dental history. In addition to that, you want to make sure that you get a good social or personal history. You have to be the type of dental professional that asks questions to get the information that you need to make the type of quality treatment decisions that your patient is expecting for you to make. With this also involves the nutritional assessment. Now, guys, I get it. I've practiced clinically as well, and I know that sometimes we are limited with what we can do. But if COVID has taught us nothing else, is we can use teledentistry to our advantage. So sometimes you may not have the opportunity to ask the questions right there in the chair, but let's use some of the other means that we have access to help our patients. Then you can also ask basic questions like, do you have pain What type of pain is it? Does it linger? Is it spontaneous? When are you experiencing it? Where are you experiencing it? And what is happening when you experience this pain? And then let's just say, if you ask your patient, are you experiencing pain? They say yes. Well, that's a closed-ended question. So what you want to do is learn how to ask questions in a more open-ended fashion. So where do we go wrong? I think we go wrong because we don't think that this is an important part of clinical management of dental hypersensitivity. In fact, there are studies that show that an often neglected phase of clinical management is removing the causative factors that even prevent dental hypersensitivity from occurring or reoccurring. So we have to be really, really thorough in our assessments. We really do. We also need to consider the age of our patient. We need to consider their temperament and other things that may be going on. And, when we conduct these assessments and we have an opportunity to pull all of this information together, we are going to be able to decide the very best treatment options for our patients. What we want to do when we are trying to decide what the causative agent is that we are also ruling out everything else. We want to rule out the things that we can exclude. Sometimes dental hypersensitivity can be mistaken for someone who has a tooth that requires endodontic involvement. Sometimes people are suffering from occlusal trauma. There are people who experience, they clench and grind their teeth. And then sometimes you have people that simply have a, recurrent carious lesion. But as I stated very early on in this presentation, sometimes your patients are suffering from multiple conditions. So it's with that thorough assessment that you may be able to identify that not only is your patient suffering from dental hypersensitivity, but they also have a recurrent carious lesion and they also have occlusal trauma. So this, again, just allows you to provide the very best treatment for your patients. So what are some of the things that you must consider before deciding on treatment? And, we've talked about some of those before. So number one, we have to determine what the cause is. And I'll be honest with you, sometimes you may not be able to determine the cause. You need to know your patient. Who is your patient? Is your patient going to be someone who's very compliant? Is your patient going to be someone who is receptive of the information that you give them? What is the condition of their mouth? Are they suffering from other dental conditions? So let's just say, in addition to dental hypersensitivity, they're suffering from xerostomia and they have problems with periodontal disease. So when you are deciding on which product to use, maybe you want to come up with a product that not only treats the dental hypersensitivity, but it also treats xerostomia, and it also has an ingredient that may help fight off some of the bacteria in the mouth. What do you want your product to do? And that's going to be key. There are so many different products on the market that treat dental hypersensitivity. And while a lot of them are similar in nature, the different ingredients allow them to behave differently. So you have to decide what it is you are expecting your product to do. And do you even know what the product can do? Sometimes a lot of us, especially if you're temping, you walk into an office and you use the products that they have there. You know that it helps with dental hypersensitivity, but outside of that, you really don't have a clue what the mechanism of action is. So you have to know what the product does. And then, is it easy to use? I think back to very early on in my career, There was different ways that they were doing these site-specific antimicrobial treatments. And I was in love with the Perio chip. Love, love, love the Perio chip. The problem is that it wasn't easy to use. So I had to then go to something else because I found out I kept breaking the chips or the chips wouldn't fit into the pocket. So not only was it costing me time, it was costing the office money. So definitely think of all of these things before you decide upon a product. So the various products that are used to treat dental hypersensitivity are broken down based on the ingredients that are contained in them and the mechanism of action. Then they are further classified as, does it stabilize the nerve, or does it occlude the tubules? Or is it invasive or non-invasive? Again, and I stated this earlier, you always want to use the most non-invasive method for treating dental hypersensitivity. Now, it is going to be impossible for me to focus on every single treatment modality, but there are a few that I want to give greater attention to this evening. So we talked about method of action. There are two primary mechanism of actions when we are talking about dental hypersensitivity. The product you use is either going to depolarize the nerve or it is going to occlude the dental tubules. So if you have a product that is depolarizing the nerve, what that product is doing is that it's stopping the neural signaling. What happens is you're not stimulating those myelin A fibers, and that eliminates the transmission of pain to the brain. So we are not going to experience the hurt. The problem with this is, though, the tubules are still open. The tubules, in some cases, you have that fluid that's still moving back and forth, and you still have that pressure. So that is why sometimes when patients are given products that are designed to depolarize the nerve, they still experience pain. Now, remember when I said there are some teeth that have up to 30,000 tubules, okay? So you want to make sure that you are able to treat that entire tooth surface. So that is why sometimes, again, when you give somebody a product that is designed to depolarize a nerve, they could potentially still be feeling pain. Now, if you have a product that is designed to occlude the dental tubules, what it is that you're setting up a barrier. Okay, you're blocking the tubules. So there's no back and forward flow, and there's no neural stimulus. Products that are designed to depolarize the nerve are typically your nitrates, so your potassium nitrate, and then products that are designed to occlude the tubules typically are your calciums, your fluorides, your oxalates, and your strontium salts. So I can admit that very early on in my clinical practice, I used what we had in the office. I used what we were given at conventions, or, you know, just what my local rep came in and talked to me about. And then me personally, I suffered a lot with dental hypersensitivity. And I realized that at that time, I really wasn't paying attention to the science. And when I started to ask those questions. Number one, what is causing this dental hypersensitivity? For me, it was the obvious, it was the lemons, right? But what is it that I'm expecting this to do? How soon am I expecting to, receive relief? Are there any side effects from what I'm going to use? And is this treating any other condition in my mouth? So here is a list of the various treatments that are available for dental hypersensitivity. So of course you have your fluoride varnishes, silver diamine fluoride, you have your glutaraldehyde HEMA, you have your oxalates, new nanotechnology, you have agents that contain calcium and arginine, your laser treatment, so even grafts. And grafts to me probably is the most invasive type of treatment. So we don't want to get all the way to the other side of the rainbow, if you will. All of these treatments can be effective. And that is important to note. I am really not here to promote one method of treatment over the other because, again, each of them can be effective. But we know with dentistry is that there is no one size fit all for every condition. And so depending again on those other factors that call those causative factors that are contributing to dental hypersensitivity, sometimes that lends itself to the type of treatment that you must select for your patient. So the very first thing you want to start with outside of identifying the causative agent is a simple over-the-counter treatment. And again, we do this when the removal of the causative agent proves to be ineffective. This is considered a second line of defense. Your over-the-counter treatment, so your at-home desensitizing agents, are your second line of defense. And they typically include the use of paste, mouthwashes, and chewing gum. These over-the-counter treatments are also the most cost-effective for your patient. Usually these products, most often the paste, contain 5% potassium nitrate. And remember, we said those depolarize the nerve. And with these, you can expect to experience a reduction in sensitivity in 2 weeks. Now, some of the other at-home dentrifices have 0.45% stannous fluoride, and those are designed to block tubules. And again, it takes about 2 weeks. Now, the problem that we run into is patient compliance. So remember, you have to know your patient. There's also some evidence that has been published in the literature that proves incorporating bioglass into toothpaste helps to occlude tubules. And bioglass is simply composed of a specific percentage of silicone, sodium, calcium, phosphorus oxide, and sometimes fluoride. And when this bioglass comes in contact with the saliva, it develops a protective layer of hydroxyapatite over the tooth, and that helps to occlude the tubules and decrease the flow of fluid in the tubules as well. Sometimes the potassium nitrate and bioglass and various fluoride solutions have been incorporated in paste. It just really depends on the product, so to speak. We know that oxalates can be very effective. They have also been found in different paste as well. Oxalates are unique because they, again, help to occlude the tubules, but they are insoluble in acids, so they can remain intact, not only when they are exposed to mechanical challenges, but when they're exposed to acid challenges as well. You then have your prescription strength dentrifices, which can be used at home, and they contain, your ACP, your CPP and ACP, which is known as the recaldent technology. And you have some that contain tricalcium phosphate as well. They all help to reduce sensitivity by accelerating the remineralization process. And they also work to help occlude the dental tubules. So when you are recommending any type of over-the-counter or prescription dentrifice, it's important to educate the patient on the proper use of these products to achieve the desired result, because the effectiveness on these products rely heavily on how compliant your patient will be. It also requires your patient to be patient, okay? Some of these products, especially the non-prescription strength, take 2 to 4 weeks to provide relief for your patient, and they must be used consistently. And it is also worth noting that your patients have to be instructed to use a minimal amount of water. So if you think about it, when we brush our teeth, there's lots of water, and especially patients outside of the profession, if it's not bubbling up like a rabid dog with foam all over the mouth, it's not working. And so a lot of these products, they don't do that. And the patients, in some cases, depending on what you give them, they're not even supposed to eat, drink, or rinse their mouth out. So this is why a lot of the times the over-counter treatments are just not really effective. Now, we talked about those prescription strength paste, And we talked about the different things that they contain. So again, we talked about the CPP and ACP with the recaldent technology, and you're going to find that with your MI PACE. And then we also talked about the tricalcium phosphate that is used to treat dental hypersensitivity as well. Your TCP is the newest member of the calcium phosphate family. And what it does is that it works to enhance remineralization through the slow release of calcium on the tooth surface. Now, you also have a new technology, the nanotechnology is what I like to call it. And so you have a paste here, Remimpro, that contains nanohydroxyapatite. And what really works well with this is that this paste fills the little superficial enamel lesions, these little tiny lesions that we can't see that happen on the tooth surface because of erosion. And it also helps to restore the mineral balance to the tooth. So again, like most other pastes, it definitely works to enhance remineralization and decrease demineralization. Another added benefit to this paste, again, is that it contains fluoride and xylitol. So I talked about the patient who has multiple issues. So if you have a patient who is suffering from periodontal disease, if you have a patient who's suffering from xerostomia, and you have a patient who's suffering from dental hypersensitivity, you now have a product that can treat all three of these conditions. You also have to consider the patient who may have some sort of allergy. And so the good thing about Remimpro is that it is void of a milk protein. Again, we talked about that nanotechnology. For those of you who are not familiar, hydroxyapatite is what our teeth are made of. Okay, 90% of our enamel is hydroxyapatite, and 70% of our dentin is composed of this. So I want to talk about varnishes. Varnishes are fascinating to me. They really, really are. And I love studying about varnishes because, you think that varnishes all do the same thing, and they really don't. So varnishes actually were approved for use in the United States in 1991. So varnishes, they're a concentrated form of sodium fluoride, and they're typically suspended in an alcohol and resin-based solution. Your varnishes are approved by the Food and Drug Administration as a Class 2 medical device. So they have been cleared to be used as a cavity liner or a desensitizer. Most people use fluoride varnish as an off-label use for caries protection. So again, FDA has approved it as a desensitizer, but the ADA promotes it for caries treatment. And what research tells us that when this is applied 2 to 4 times a year, varnishes can have an effect on inhibiting caries formation. And it's amazing. Remember, we talked about erosion. Erosion and dental caries formation share so much. They share a lot of common factors. So if you are treating erosion, you're likely treating or preventing caries, and vice versa. So there are about 49 different varnish products on the market. So how in the world do you choose? Most people are going to make their selection based on price. And that's not always a good thing. Varnishes, most of the time, they really behave similar yet different. And you should never just have one varnish in your office because they do very different things. And again, we shouldn't treat our patients with a one-size-fit-all approach. All varnishes have some form of film-forming agent. And then that's called colophony. They have solvents and flavors in there. They have sweeteners, and then they have those special additives that aid in remineralization. The vast majority of varnishes are composed of 5% sodium fluoride, which is also expressed as 22,600 parts per million. For children, that dosage is 2.25. All varnishes are really safe if dosaging guidelines are followed. The additives that I just referred to, I'm really referring to things like the calcium, the casein, phosphopeptides, the ACP, um, all of those other things. Some of those we've also discussed earlier. So it's important that you know how your varnish performs and how each ingredient performs in the overall solution. So a lot of your varnishes are resin based, and the resin, that colophony that I talked about, that is the most common resin additive, and it's derived from pine tree sap. That is what allows the varnish to stick to the teeth over a period of time. And because the varnish is able to stick to the tooth, it's allowed to release the fluoride. This colophony is also responsible for leaving that sticky film on the tooth surface. The alcohol, remember I said most varnishes or all varnishes have alcohol. The alcohol is what allows the varnish to dry and set rapidly on the tooth. So then you have the different solvents inside your varnish, and those solvents, depending on what they are, impact the viscosity of your varnish, the spreadability of it, how soluble it is, how it migrates in the mouth. It also affects the fluoride ion release profile of the varnish, and all of this impacts the varnish behavior. The behavior is what differentiates one varnish from the next. There are some varnishes that have a very high solubility and will release fluoride very, very fast, or faster than those that have a more limited solubility. Ideally, you want a varnish that has a lower solubility so that it is there and it is allowed to release fluoride over a sustained period of time rather than a really, really quick uptake. However, in some instances, depending on the type of patient that you're dealing with, you may want a varnish that releases the majority of the fluoride in a shorter amount of time. Of course, you have your different flavors in your sweeteners that affect the palatability of varnishes. So you have some varnishes that taste really, really good and some varnishes that make you cringe. We talked about spreadability in migration, and that really refers to how easily can you apply the varnish to the tooth surface and how it spreads to other areas of the mouth. So a varnish that has really good spreadability and has really good migration, you only have to apply it on the facial surface and it migrates to the proximal and lingual surfaces before the solution sets. So this is a great feature to have for children or people who don't want to behave. And then, your calcium additives are important. Calcium is always going to be very important in a fluoride because it increases the bioavailability of fluoride, which in itself impacts the performance of the varnish. So what happens once you apply the varnish to the surface? So the fluoride ions are absorbed, okay? And we know that fluoride acts to inhibit the demineralization and also acts to enhance remineralization. The fluoride ions that stick to areas of the teeth that have been demineralized. And it's important to note that the fluoride ions are going to migrate to the areas that have been demineralized. These ions integrate with the hydroxyapatite. And the fluoride ions that are attracted to the calcium, fluoride ions are also attracted to calcium and phosphate in the saliva. When your fluoride is able to combine with calcium and phosphorus, they form a crystalline structure known as fluorapatite. And this has a lower solubility profile than the hydroxyapatite. And this is good because it can withstand the environment in your mouth. It will disassociate at a much lower pH level, meaning that it'll just stay intact the lower the pH goes. Eventually, though, if the pH drops below a certain amount, it will disassociate. Calcium additives and varnishes will also behave differently. So your calcium will combine with fluoride. They form insoluble globules inside the dentinal tubules. And when this happens, you get the greatest hypersensitivity relief over a sustained period of time. Again, because these globules are not as sensitive to the changes in the pH in the mouth either. So there's a bonus here. There are some patients who are allergic to that resin inside of the varnishes. And for those who are allergic to that, but they still want the benefit of a fluoride, or you have people who just absolutely don't want that sticky feeling on their teeth, there are liquid fluoride solutions. Voco does offer a liquid fluoride solution, Pro Fluoride L, and Elevate has FluorMax. I have personally used Pro Fluoride L. I have recommended it for patients before the bleaching process. So think about it. There are patients who want to whiten no matter what you tell them, and no matter how sensitive they get, they're still going to want to whiten. So this is a great product for those patients so they can whiten without the pain. But I am a huge advocate for pain management in the dental hygiene chair. There are some patients that you can't even probe without them flying out of the chair. And what I find is that far too often, many clinicians will just skip around that tooth or get frustrated with the patient, and there's no need to. You are able to provide that patient with relief without that sticky feeling so that you can do the job that you need to do. Your patients are going to come back to you if you don't hurt them. And in addition, these liquid varnishes, especially Pro Fluoride L, it not only provides immediate relief, but it can provide long-term relief against the sensitivity. Again, how do you choose? How do you pick? All varnishes, again, they work to occlude the tubules and release fluoride. So you want to think about your fluoride uptake. That is a key feature of varnishes. Do you want the fluoride varnish to exhibit fluoride uptake 24 hours after an acid challenge? So do you still want it there doing its job? But you want to consider the delivery system, again, how easy it is, consider those additives, and consider the performance. There are so many different things to consider. And again, really great products on the market. Silverdimene fluoride. I know that there has been a huge rave about silverdimene fluoride and how it can be used to fight caries. But again, silverdimene fluoride, like your fluoride varnishes, it has been approved for the use as a treatment for dental hypersensitivity. So they were starting to study silverdimene fluoride back in 1969, and it was approved in 2014 by the FDA as a Class 2 medical device. And so what is so wonderful about silverdimene fluoride, the silver, in fact, it is the silver. What we know about silver is that it is antimicrobial. So it can damage the bacterial cell wall. It can also inhibit the respiratory response. But silver in the silverdimene fluoride solutions is what blackens the tooth. As it states, silverdimene fluoride has fluoride in it, but it has twice the amount of fluoride than your varnishes at 44,800 parts per million. Again, silverdimene fluoride creates fluorohydroxyapatite crystals, which we know hold up better than your traditional hydroxyapatite crystals. They contain ammonia. Ammonia is placed in these to reduce the oxidative potential of the silverdimene fluoride. Again, it makes it more stable in the mouth. And then you have a silverdimene fluoride solution that contains the potassium iodide. And what this does is that it binds with the free silver ions, and it helps to minimize discoloration. There are two silverdimene products currently on the market, silverdimene fluoride, that's Advantage Arrest, and then Riva Star. Riva Star is a two-step system, and it is what this two-step system, that second step, that helps to minimize the discoloration or eliminate it altogether. I do want to mention that both can be used without discoloration on intact tooth structure. It's when you have to use it on a surface that's not intact that you're going to get that black color. But again, with the Riva Star and the addition of that potassium nitrate, you won't get that discoloring. This is just an article here about the Washington Post, and I wanted to highlight that they are saying that silverdimene fluoride is the single greatest innovation in pediatric dental health in the last century. So this, again, it's used off-label to help for caries, but I want you to know that it works wonderfully for dental hypersensitivity. There are patients who can benefit from it and patients who cannot use it. But again, patients really experience long-term, like more long-term relief, up to 2 years in some instance, when silver diamine fluoride is used to treat dental hypersensitivity. So that's very, very important. Glass ionomers is something else that can be used to treat dental hypersensitivity. So they are created by mixing an acid, usually an acid with a base to form a salt, and that results in the glass ionomer. This typically requires water. The advantage of glass ionomers is that you get an initial burst of fluoride, and then you get continued release of fluoride throughout the year. So your tooth is constantly being remineralized, and that helps to preserve tooth structure. So this is something else. Again, this is a little bit more invasive when you start to bond things to the tooth, but it's shown to be really, really promising. And in areas where you want to use silver diamine fluoride, sometimes you can put a glass ionomer on top of it, or instead of using traditional resin-based sealants, you can use a glass ionomer instead. Your glass ionomers typically have ACP in them, and research has shown that ACP can, as needed, trigger the slow release of calcium and phosphates, and that has demonstrated the ability to remineralize tooth structure. So think outside the box, especially if you're a dental hygienist. Having glass ionomers and silver diamine fluorides can solve a lot of problems and can definitely be a great addition to your treatment selection. Very, very great. So, the last thing is that you want to make sure that you are educating your patient. Clinical management of dental hypersensitivity is definitely possible. It should be based on etiology and severity. Consider at-home and in-office therapies. Your management also involves patient education. You as the clinician are responsible for creating that awareness. You want to listen to your patient. Don't dismiss your patient. Don't undertreat your patient, but you also don't want to overtreat your patient. Modify habits where you need to, and make sure that you are doing those assessments. Ultimately, it is up to us to understand the science behind what we are using. That is the premise of evidence-based dentistry. Management can be accomplished with a variety of different products. Make sure that you have a solid understanding of how the product behaves, and make sure that you are maximizing effectiveness by using these products according to the manufacturer's instructions for use. Ultimately, we want to have our patients achieve optimal oral health and give them a beautiful smile. Did you know that we're actually born smiling? More than 30% of us smile more than 20 times a day, and less than 14% of us smile less than 5 times a day. In fact, those with the greatest superpowers are children, because they smile as much as 400 times per day. I want to thank you for joining me for this presentation. Now I can use this time to answer any questions you may have. So the first question is the acid challenge from coffee, tea, and soda from sucrose exposure, or the acidity of these substances? And the answer is both. If you understand how sugar is metabolized in the body, then you will also understand that there can be some acid related to that. Second question is, why do people have a lot of erosion from lemon eating, drinking, not have sensitivity? Well, sometimes it depends on the structure of your teeth. It really just depends. Again, so that's like, why do some people can eat all they want, never have to exercise? I'm not one of those people. I have to exercise if I want to eat. So yes, that has a lot to do with the anatomy and the porousness of your tubules, how wide they are, and maybe how many that are present. With patient wearing masks throughout the day, I've noticed an increase in sensitivity on the maxillary anterior. Is this sensitivity of the gingiva or teeth? That's where you have to rule out what those causative factors may be. It's hard to say what it could be, depending on what else the patient is doing. But a good solution, again, you always want to start with the most basic things. So something over the counter, or maybe a prescription paste, and that may help. Allison says, when you mention coffee and tea affecting the pH level, is that with sweetener and or a milk product, or does plain tea and coffee affect erosion as well? So the second part to that, does plain tea and coffee affect erosion as well? Yes, it does. Now, one thing, without going too far off track, sometimes dairy products can affect how acidic something is. So you may be able to balance out the erosive potential and the carcinogenic potential of your beverages by balancing it out with a dairy product or sometimes a protein. Can we put fluoride varnish to help with sensitivity? I believe we answered that, but absolutely, yes, we can. Again, fluoride varnish has been approved by the FDA to treat hypersensitivity. We just use it off-label for caries prevention. We're rinsing with an over-the-counter fluoride rinse after acid exposure or meal help strengthen the weakened enamel or dentin? Yes, it could. You just have to understand how that mouth rinse behaves, and you need to understand what's in there. I am unfamiliar. I can't read this. I'm sorry to that person. And is 2 weeks a good follow-up interval for any intervention? Absolutely. And again, you don't necessarily have to have that patient come into the office. I think we can use the technology to our benefit. I was taught that fluoride shouldn't be administered at a prophy prior to restorations and applied after the restorative portion of a visit. Yes, I have heard that. And again, you have to understand how that fluoride behaves. So typically most fluorides had to be left intact and undisturbed in order for the tooth to benefit from the full fluoride uptake. So depending on the type of product that you're using, that may or may not still hold true. What is the efficacy of fluoride foam for desensitization? Again, you are looking at the ingredient and the additives. And I think that foam can really be effective because at the end of the day, we know, let's just say your foam had a stannous fluoride in there, it's going to occlude the tubules. The problem is, I don't think most people use foams the way that they're supposed to. And then there's also compliance with the patients afterwards. Why do fluoride trays cause stomach upsetness while varnishes don't even? That's probably because people are swallowing some of the fluoride with the use of those trays. I've seen doctors use silverdimine fluoride and apply varnish over it. I've seen that as well. Can you repeat the name of the Voco product with fluoride? I've talked about two products, RemenPro, which is the paste, and then the Pro Fluoride, which is their varnish. That's their resin-based varnish. And then Pro Fluoride L is the liquid varnish. What is the best product to recommend for people who are all natural and refuse fluoride? Wow. I have a few other questions I need to get to. That's a hard one. Let me come back to that. Which fluoride varnish did you say is good for when probing gingiva? That was the Pro Fluoride L, because when you're probing, you don't want that sticky paste on the tooth surface. Pro Fluoride L, I think I answered that question. What are your thoughts about mineral water? I love mineral water. What is my preference? Varnish versus a gel. I'm a varnish girl. As an EFTA, how can we play a part in telling patients about diet and cavities? Absolutely. To all of my dental assistants, you are a part of the team. So number one, just educating yourself about the importance of nutrition and oral health. And then, you help with having the conversation, because our patients are spending just as much time with you as they are in the hygiene chair. So this presentation was a great start for you. Thank you for that question. What is the key in choosing between fluoride varnishes and silverdimine fluoride? The key is, what do you want it to do? You have to decide what it is that you want it to do and how comfortable are you using silver diamine fluoride. And I'm going to take one more question because I want to be mindful of time. What would be the best way to prevent hypersensitivity on patients? The best way would be to have a conversation, find out what those causative factors are, and then based on the conversation that you have with your patient, the type of patient that you have, what your patient can afford, because sometimes, unfortunately, that is a factor. You can then decide the best product to use. And that's it. I want to be mindful of time. I'm getting a cue here. Guys, if you have any further questions, definitely feel free to email me. I'll be up for a little while and I would be happy to answer your questions. So info@drjoyrdh.com. I would be more than happy to continue the conversation. Thank you very much. I appreciate you all, and a happy and prosperous new year to you.